Welcome to the University of Washington Regional Heart Center Grand Rounds. I'm Rick Page, head of the Division of Cardiology at the University of Washington, and today it's my pleasure to introduce Karen Stout, acting assistant professor in our division, and Tom Jones, associate professor of pediatric cardiology, who are going to speak with us today about congenital heart disease in the adult.
Thank you, Dr. Page. I've chosen a case that should illustrate a variety of issues related to congenital heart disease in adults, which is a growing patient population, as I hope you'll see. Our patient is a 27-year-old man who was admitted with an episode of hemoptysis. He'd been coughing up blood on an annual basis, essentially, for several years, but this particular episode, he coughed up a cup of blood in the span of 5 to 10 minutes, became alarmed, and presented to an outside hospital. He has a history of a congenital heart disease, having been born with transposition of the great vessels. He underwent a mustard repair at age 3 months, and we'll discuss both of those in some later slides. He'd been coughing up blood about a week prior to admission, but scant amounts. And as I said, it was this substantial increase in the amount of blood he was coughing up that prompted him to return to an emergency department near his home. While in the hospital elsewhere, he was evaluated for possible sources of bleeding, and they were unable to demonstrate either a nasal source or a GI source of his blood loss. He was transferred here to the University of Washington, and he had a thorough evaluation, and part of that included a CT scan. And the clinical suspicion when he presented here was that he had had a pulmonary source of bleeding, and the CT scan confirmed that. In the left lower lung here, hazy opacities that were felt most consistent with blood in the airways. Further reconstruction of the CT scan from a cardiac perspective gave some clues, which we already knew, but gave nice representation of his underlying cardiac anatomy. Under normal circumstances, the aorta comes off of the left ventricle. However, in his case, he has transposition of the great vessels, and that's not his anatomy. In utero, the aorta and pulmonary artery are a single blood vessel that come off of the heart. Under normal circumstances, there's a spiral division between the two that allows the pulmonary artery to come off of the right ventricle, where it should, where it can take blood out to the lungs, and the aorta to come off of the left ventricle to take oxygenated blood out to the body. In his case, when in utero, that big vessel was divided straight down the middle, and that separation that should occur did not. As a consequence, his right ventricle, which is here, it's an anterior structure, is attached to his aorta, going up and over, also an anterior structure. The left ventricle is posterior, giving rise to the pulmonary artery. This is also seen in the two-dimensional cross-sectional slices where the aorta, which is normally a posterior structure, is anterior, right here next to the sternum, and the pulmonary artery is posterior, back here by the bronchi. An echocardiogram was performed, again demonstrating the same anatomy. This is a peristernal view from up here next to the sternum. This is the right ventricle, which is very hypertrophied because it's actually pumping against the systemic blood pressure, which it's not accustomed to doing, and therefore it had to get larger in order to accommodate that workload. The left ventricle is posterior, as one would expect. As I said, this was a big blood vessel in the womb that should have divided in a spiral fashion and did not. Under normal circumstances, the valves that lead to the aorta and the pulmonary artery, respectively, are perpendicular in orientation. In this circumstance, they're parallel in orientation, which is absolutely classic for this particular congenital abnormality. The aortic valve is up here, anteriorly, and the pulmonary valve is posterior. This is a similar view, the same anatomy with an anterior aortic valve and a posterior pulmonary valve. Looking at his heart from out here at the apex, this is a very hypertrophied right ventricle doing more work than it was necessarily designed to do. The left ventricle, on the other hand, is taking a cush road, working against the pressures in the lungs, and is relatively normal size. In his case, a mustard repair, which we'll get into in much more detail, was done to redirect blood flow at the atrial level. And as the sonographer scans through here, there are redirected blood channels, one right here into this atrium, and another comes along here into that atrium. That assures that blood is actually mixed at the levels that it should be mixed at, and you get oxygenated blood out to your body. In his case, his hemoptysis was felt likely due to aortopulmonary collaterals, which are abnormal blood vessels connecting the aorta to the lungs. He was therefore taken to the cardiac catheterization laboratory by Dr. Jones, who will discuss the images, and Dr. Goldberg, another interventional cardiologist here at the University of Washington. Because he was known to have an anomalous origin of his left subclavian artery, the cardiac catheterization was performed through his left wrist. I'll now introduce Dr. Tom Jones, who's an interventional cardiologist who works both at Children's Hospital and Regional Medical Center, as well as here at the University of Washington, who will discuss the cardiac catheterization findings.
Well, thank you, Karen. It's a great opportunity to join you again for your Grand Round session here. The case that Karen has described is a patient who was originally cared for as a newborn at the at the Children's Hospital, and had his definitive palliation done when he was 3 months old. At the time of his initial evaluation, we understood that there was an additional anomaly of the arch of the aorta, which we will get into further review of here in a moment. What became apparent in the course of his evaluation here that included the CT scan was that in addition to the transposition physiology that Karen described, we also knew that he had a right aortic arch, meaning that the aorta, as it left the heart and descended into the chest, instead of coursing normally on the left side of the chest, it went to the right side of the chest. And this created a specific issue when it came to evaluating the source of bleeding in the lungs. We suspected that there was a source of blood flow from some large arterial structure that was entering the lungs and causing this bleeding problem. Now, as it turns out, it came from the artery to the left arm, and you can see in this particular injection here that blood is coursing, or contrast is coursing down into the left lung here and producing staining within the lung, and you can actually see the blood flow entering the arteries within the lung itself. Now, as it turns out, we were only able to access this vessel from the left arm. Normally, that subclavian artery would arise from the aorta, but in this case, the only way that blood flow reaches that left arm artery is going through collateral circulation, arising from the blood vessels going up into the head and then coming back down the neck into the left arm. Now, to reach this blood vessel, we couldn't come in from the blood vessels in the leg. The arteries from the leg that would allow access to this vessel normally weren't connected. We had to come into the artery to the arm through the left wrist. And this is where Dr. Goldberg's expertise in doing radial artery catheterization came into play. And here you can see the blood flow coming into this lung vessel from the catheter that's been inserted in the wrist artery on the left side. In this next injection here, what you can see is that we've deposited some embolization coils. These are stainless steel metallic coils that have Dacron fiber embedded in them, and that vessel that you see with the coils in it was the largest of the blood vessels that was supplying the blood flow into the lung. Now, with this injection, the catheter is filling a blind-ended beak there that runs down towards where the subclavian artery would normally connect to the aorta. And you can see that most of the blood flow into that left lung is closed. However, we did define, somewhat more superiorly towards the head, another small tortuous blood vessel that when entered, we discovered was a source of additional blood flow into the lungs. Now, to enter this vessel, you can see how tortuous and complex the course is here. We introduced a special catheter inside that existing catheter and was successful in depositing several tiny microcoils within that collateral vessel. These are coils that were originally developed for neurosurgical, neuroradiological interventions, and in this case were successful in eliminating the shunt flow into this patient's lungs. Now, aortopulmonary collateral vessels are something that are not unusual in the context of complex congenital heart patients. These are defined as vessels that arise from the aorta or one of its major branches and enter the pulmonary artery bed. They are either the enlargement of normal bronchial vessels, hypertrophy bronchial vessels, or they are abnormal vessels that develop from the chest wall itself into the lung, and often those will occur along the line of previous surgical adhesions created from earlier thoracotomy procedures. The cause of these vessels is is poorly understood. It has always been assumed to be related to cyanosis or blueness with the stimulus that produces for developing increased blood flow to the lungs. But it's been also described in other instances, for instance, in circumstances where there's low pulsatile flow into the blood going to the lungs, or in the setting of chronic infection, trauma, or even in the case of some cancers. These AP collateral vessels are often identified in the course of doing a thorough echocardiographic examination, but a better and more definitive procedure is cardiac catheterization with contrast injection directly into the aorta or into these branch vessels. We sometimes will define these by an increase in the oxygen content measured between the veins entering the heart, the vena cava, and the distal pulmonary arteries. At other times, we will actually define these by direct opacification on angiography, either of the aorta or selectively into these vessels. They can also be determined when contrast is washing out during pulmonary arteriography, or there's a failure of a pulmonary artery segment to actually be identified during pulmonary angiography. In this particular patient, the Edwards embryologic arch plan is defined here. Now, this is a theoretical plan of development of the arch vessels during embryonic life in the human. This represents the ventral, or the portion of the aorta towards the front, and these arches the dorsal aortas. Now, in a classic double aortic arch, both of these arches will persist. In a normal patient, there's regression of the right aortic arch from this point here downward, so that the first branch of the aorta is a right brachiocephalic artery trunk, giving rise to a right carotid artery and right subclavian artery, the second arch vessel being the left carotid artery, and the final branch being the left subclavian artery. In our particular patient, a very rare anomaly was superimposed on what was already a rare complex congenital heart defect that included the persistence of a right aortic arch and interruption of the left-sided dorsal arch. So for this anomaly to occur, there would have to be regression of the aorta between the left carotid artery and the left subclavian artery, as well as the dorsal portion of the left aortic arch. So in this particular patient, the left subclavian artery was isolated, and the only way we could access this vessel for the purposes of closing those abnormal collaterals that arose from this vessel was to come up through the arm as shown in those angiograms. Blood flow to this patient's left arm is supplied by blood flow entering the left and right carotid arteries and the right-sided vertebral artery, going up into the head, crossing through collaterals in the base of the skull, and coming down into the vertebral artery on the left side and providing blood flow to the left subclavian artery. So this particular patient, in addition to presenting with his unusual congenital heart defect, transposition of the great vessels, also had what amounts to a very rare aortic arch anomaly, and one that escaped detection during his initial evaluations. And it wasn't until the combined teamwork approach that included Dr. Goldberg and myself, we were able to define this and proceed with the coil embolization procedure that was successful in eliminating the patient's pulmonary bleeding problem. So I'll turn this back over to Karen. Thank you.
Thank you very much. So the patient, aortopulmonary collaterals and causing hemoptysis are a potentially life-threatening problem. He actually did extremely well. He had those two vessels coiled, was observed for several more days in the hospital, and was discharged and has been doing extremely well since that time. He raises a couple of issues. The first is these are unusual cardiac abnormalities. However, they really emphasize that you have to expect the unexpected. They have one rare abnormality. This is exactly the kind of patient population who will have yet another rare abnormality. So merely understanding their underlying congenital heart disease may or may not be sufficient to fully evaluate these patients. They have a variety of different abnormalities that can coexist with whatever you know to be underlying. In his case, he raises two other more global issues. The first is exactly what is transposition of the great vessels, what is his underlying anatomy, and what are the long-term expectations for this young man. The other is overall care of adults with congenital heart disease. These are unusual abnormalities, but they're increasing surprisingly in the adult population, and we'll show you why. And it's not something that typically is seen in adult cardiology practice. There's smatterings of it as these folks get into adulthood, but caring for these patients requires additional expertise in congenital heart disease. Transposition of the great arteries represents 5% of congenital heart disease. It's a ratio of 3 to 1, male to female. And adults with complete transposition of the great arteries have to have had surgery to survive. So these patients have all had at least one surgical procedure in their infancy, typically. The essential problem is, as we mentioned earlier, these two great blood vessels are coming off the wrong ventricles. So blood flow returns from the right atrium into the right ventricle. This blood has no oxygen, and it comes back in the usual fashion, but then goes out the aorta, carrying unoxygenated blood to the body. Blood that is in the lungs returns in the usual fashion to the left atrium, then the left ventricle, as would typically occur, but then goes back out to the lungs. As a consequence, these patients have two parallel circulations. There's unoxygenated blood out here circling around in the body, and oxygenated blood circling around in the lungs. For survival, there has to be a connection made between these two circulations. This is a normal arrangement where unoxygenated blood is taken from the body back to the lungs, gets oxygen, heads back out to the body. Trying to reapproximate this is done in a variety of different fashions, and the first one was done in 1954, an atrial level switch. The mixing of the blood can occur at a variety of levels. It can occur at the atrial level as blood returns from the body or the lungs respectively. It can occur at the ventricular level, or it can occur at the level of these great vessels. From a surgical perspective, the first of these attempts at physiologically fixing these patients was done in 1954 by Dr. Senning. Dr. Mustard also did a similar procedure shortly thereafter. Flow in this circumstance is brought in, blood flow without oxygen, into the inferior vena cava, superior vena cava, is brought back, and rather than allowing it to go to the right atrium where it would have, it's redirected across to the left atrium, left ventricle, and back out to the lungs where it can get oxygen. Oxygenated blood then returns here to the left atrium and the left ventricle, and then through these surgically created baffles is redirected over here to the right atrium, into the right ventricle, back out to the aorta. By redirecting blood flow, you're now allowing oxygenated blood to get out to the body where it belongs, and blood without oxygen to get to the lungs where you can have it pick up the oxygen that it needs. The drawback to this particular repair is this right ventricle. The right ventricle was not designed to work as hard as it has to, pumping against this aortic pressure that it's now left with. These baffles can be hard to find. Echocardiography is generally ideal. This is a picture, a still echo, of another patient of ours who has transposition of the great vessels, showing blood flow coming back from the pulmonary veins into one of these baffles and being directed over here to the left ventricle, which is not the usual arrangement by any stretch. There are complications of this repair. The right ventricle functioning as a systemic ventricle, pumping against a standard blood pressure of 120/80, doesn't do exceptionally well. Additionally, they can have some degree of exercise intolerance. These patients actually do remarkably well. 80% of them are minimally limited in their day-to-day living, which is sort of surprising when you look at what their anatomy was when they were younger and what they're faced with now. But sometimes their heart rate is just not able to get high enough to allow them to exercise maximally, which is known as chronotropic incompetence to those who deal with things such as inadequate heart rates. Death, which can occur in some percentage of these patients, is usually due to sudden death from ventricular arrhythmias, or occasionally due to failure of that right ventricle that's not accustomed to working as hard as it's having to. Tachyarrhythmias, or fast heart rhythms, can occur, and they particularly occur around the scars that were created in the atrium at the time of their surgical repair in infancy. These can be somewhat difficult to manage, both medically and with catheter-based approaches. That right ventricular dysfunction, it's not necessarily obvious why the right ventricle wouldn't tolerate working at the increased workload that it has. But one theory is that it gets a relative lack of blood supply because it's only supplied by a single coronary artery, the right coronary artery. The left ventricle, which was more designed to work against this aortic blood pressure, is actually supplied in some way by all 3 coronary arteries, but certainly by the 2 left-sided arteries. Those surgically created baffles redirecting blood flow can become narrow in 5 to 10% of patients, and that often has to be dealt with either by a catheter-based approach or by surgical reoperation. They also often can leak, although the majority of those leaks don't require any reintervention. The 20-year survival of these patients is 76 to 80% in large series after this atrial switch. That is a dramatic change from what their survival would be expected to be without surgery, which is about 100% at the first year of life. An overall picture, this patient represents a very growing patient population, and the reason these patients are growing is directly related to surgical improvements in surgical technology. The incidence of congenital heart disease, and this particular slide is taken from a series from the Toronto Adult Congenital Heart Disease Group, who sees virtually everybody in Canada who has congenital heart disease and has kept track of them for many years. The incidence of congenital heart disease prior to 1940 and after 1940 hasn't changed. And the 1940s are picked as a hallmark because that was the beginning of cardiac surgery. Those with severe disease hasn't changed as far as incidence. Severe disease represents half of patients born with congenital heart disease. Less severe is the other half, not surprisingly. Severe disease generally are patients who are born blue, patients who have significant outflow tract obstructions or inabilities to get blood out of their heart. Less severe disease are simple holes in the heart, which wouldn't necessarily be expected to cause anybody to die at an early age. What's most impressive on this graph is the survival to age 18. Prior to 1940, only 10% of these patients with severe disease survived to age 18. Now, because of surgical advances, 90% of these patients survive to age 18. Therefore, the total number of adults per year with a congenital heart disease has increased dramatically. The ratio of those surviving to age 18 with less severe disease hasn't changed dramatically, which is what we would expect. These patients are not your typical adult cardiology patients. They are adults, and they acquire a variety of adult medical issues that need to be managed. But their underlying physiology is not typical of the majority of adults seen in cardiology practices, cardiac surgery practices, or internal medicine practices. Therefore, the patients actually need to be very well educated about their conditions. They really need to know their prior procedures. Records may or may not be available through the usual routes, and if they have their own records, know their own history, know their own anatomy, understand or at least carry with them records of their operative reports, echocardiograms, cardiac catheterizations. Their care is made substantially easier than trying to sort of guess what's going on. They need to understand that they may need future interventions or future surgeries in order to continue to lead a healthy life. They need regular follow-up. There's a tendency for these folks somewhere between age 18 and 22 to do that checkout that some of us all did. Where they don't really keep up with their medical care. This is a patient population that very much needs to keep up with medical care on an annual basis. They need to learn to take care of themselves. These are patients who are generally identified the first day of life as having a heart problem, and they were cared for by children's hospitals exceptionally well, by pediatric cardiologists, and they are very attached to their pediatric cardiologists under most circumstances, and their parents are very involved in their care, or other family members who've been responsible for ensuring that they do well over the years. They need to understand what their medications are and why they need to take them on a regular basis. They need to kind of start thinking in their teen years and early adult years about career planning. Some of them are limited physically, and issues such as insurance are incredibly important. So in choosing careers, they need to choose careers that not only can they do from a physical perspective, but also careers that they can actually maintain health insurance. Their annual evaluations are expensive if they're having to pay for it out of pocket, but certainly their reoperations and other interventions can be exceptionally expensive if they're having to pay out of pocket for it. Life insurance is expensive for them if they're able to get it at all. Exercise is often a sort of controversial area for these patients. When they were extremely young, they were often advised against exercise because there wasn't yet a full understanding of what to expect from their heart anatomy. However, there is some level of exercise that's beneficial, but sorting out exactly how much needs to be done by cardiologists who understand the underlying anatomy. Competitive athletics are often contraindicated, but not always, and that needs to be sorted out on a case-by-case basis. They're all at risk, essentially, for infections of their heart valves or any of the shunts that they happen to have, and need to take appropriate preventative antibiotics. Family planning is a big deal, both for young men and young women. Young women, often we're told you can't have children, and that may or may not be the case. Oftentimes it is not the case, and they actually can have pregnancies that they can take to term successfully and have healthy babies. However, that's not true of every woman with congenital heart disease. So safety of pregnancy for both the mother and the baby needs to be addressed, and the genetics of the cardiac condition for both mothers and fathers needs to be addressed. These patients are at a higher risk of having a child with congenital heart disease. Their delivery should be done by high-risk obstetricians who are experienced in congenital heart disease. One overriding theme of caring for these patients is that the physicians caring for them need to have a good understanding and expertise in congenital heart disease in the adult. Cardiac catheterization, as we've already demonstrated, needs to be done by people who have an experience in both the adult cardiac diseases that are typical acquired heart disease, coronary artery disease, high blood pressure, abnormalities of the aorta, but also congenital cardiologists such as Dr. Jones, who have an experience in the congenital anatomy underlying these patients' issues. Electrophysiology, they frequently have arrhythmias, and again, expertise in both the anatomy and how to treat these arrhythmias is not typical in adult electrophysiology practices and requires additional training. Surgical involvement is exceptionally important. Surgeons are frequently involved in the care of these patients, and they often need reoperations. I have several patients who've been operated on 8 or 9 times. And the surgeons who do these operations need to have expertise not only in operating on somebody who's already been operated on 8 or 9 times, but particularly expertise in congenital heart disease and its physiologic consequences. Non-cardiac surgery should also be undertaken by physicians who have experience in dealing with these patients, anesthesiologists who have experience in dealing with these patients. So in conclusion, this is a growing patient population that's going to continue to grow courtesy of the advances of cardiac surgery and cardiology in general. So an increasingly large patient population being transitioned from children's hospitals to adult hospitals. They do require specialized care due to their unique anatomy and unique physiology. However, with excellent medical care provided under the appropriate circumstances, these patients can live remarkably healthy lives and do, in many cases, anything they'd like to be able to do. So thank you very much.
I'd like to thank the audience for attending today and thank Dr. Stout and Dr. Jones for an outstanding presentation. They're 2 members of a multidisciplinary team that includes the surgeons, cardiologists from both the Children's Medical Center and the University of Washington Medical Center who are working collaboratively to take care of these patients from infancy through adulthood. In closing, again, I'd like to thank you for attending this session of the University of Washington Regional Heart Center Grand Rounds, and I hope to see you at future meetings. Thank you.